गुड मॉर्निंग।
गुड मॉर्निंग डॉक्टर अभिजीत।
गुड मॉर्निंग सर।
क्या कैसे हैं?
मैं ठीक हूँ, आप कैसे हो?
ऑल सेट? हाँ जी,
हाँ, ऑल सेट।
ठीक।
मैं फ्लो एक बार ग्रुप पे दोबारा डाल के चेक कर लेता हूँ पहले से ही ना।
ठीक है। डॉक्टर अमित से बात हो गई है?
हाँ, मैंने सुबह जो मैसेज किया था वो उन्होंने देख लिया था।
ठीक।
मैं फोन कर दूँ क्या?
बिफोर आई फॉरगेट, ये पीयूष गुप्ता सर हैज एग्रीड टू कम फॉर 1 day फॉर द वर्कशॉप।
अच्छा, बढ़िया।
तो द डे वी हैव टू टेल हिम व्हिच डे
अच्छा,
एंड सेशंस।
गुड।
बाकी वी कैन टॉक लेटर।
हाँ, ठीक। वो हम आज ही डिसाइड कर लेंगे, है?
आज ही कर लेंगे, बिल्कुल।
हाँ, तो एक बार ही ग्रुप देख लें। इम्पैक्ट टेली डॉक्टर अमित, फिर श्री पर्णा बासु, आनंद बुटाडा, आद्या शंकर, फिर मेरा वाला आ गया। नहीं, डॉक्टर अधिसेवम तो नहीं आया ना, उनकी जगह मुरुगेशन
उनकी
है।
जगह तो डॉक्टर मुरुगेशन आ रहे हैं।
हाँ, तो मैं वो देखता हूँ मैंने।
डॉक्टर मुरुगेशन इज अ पीजी ऑफ आवर इंस्टीट्यूट।
हाँ, एंड ही डिड डीएम फ्रॉम आवर प्लेस।
ओह,
न्यूनेटोलॉजी,
हाँ,
न्यूनेटोलॉजी कलावती का है।
वेरी रिसेंटली आई।
हाँ, वो 2-3 साल पुराने ही है। जर्नल की बात 79 लो। हाँ, तो मैंने अपडेट तो कर दिया, मैं फटाफट से ईमेल करके उसको डाल देता हूँ। जर्नल की बात।
You can later on make a policy that only the senior author would be allowed to join.
अब वो ही है ना, वो बोल रहे थे कि मैं होऊंगा ही नहीं, तो क्या करें।
Then we change that. मतलब future में ना, मतलब हम कुछ ये we need to develop this also. Otherwise, चलो ठीक है, we will talk.
आना तो अभी वी आर लाइव एक्चुअली, यू
Oh,
नो। वी नेवर नो। हेलो। 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 गुड मॉर्निंग आद्या, ज्वाइन करो फटाफट। ये ना आपके लोकल लेवल की प्रॉब्लम है, आप लैपटॉप बदलो या फोन से ज्वाइन करो या लैपटॉप चेंज कर लो। ये मैक वैक का प्रॉब्लम होगा कुछ, बाकी सब लोगों ने ज्वाइन कर लिया है। आप जूम खोलो, जो मीटिंग आईडी है, और पासकोड डालो, यू विल बी एबल टू ज्वाइन। हम्म। गुड मॉर्निंग डॉक्टर श्रीपर्णा। डॉक्टर श्रीपर्णा, कैन यू हियर मी? गुड मॉर्निंग सर। सर सर वेंटिलेटर से बाहर आ जाओ, टाइम हो गया आपका, टू टू बज रहा है। 5 मिनट में ज्वाइन कर लीजिएगा, ठीक है? ओके 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 ओके।
Good morning, Dr. Vijay. I have a nephrotic range protein very honest. And was lab
Hello, Dr. Abhijit. Good morning.
Parna, can you switch on your camera, Dr. Sriparna? So we can check.
Yeah, I'm not able to do from my laptop, so I have
Fine,
switched
you
to
can
my.
do you can do from your mobile only.
Yeah.
No
Okay.
issues.
I'll stop my. Otherwise, it will create
Yeah.
echo.
Dr. Adya, can you speak something so that we can know that you are audible?
Yes, sir. I can hear you. Good
Okay.
morning, everyone.
Good morning, Dr. Adya. Good morning. So Dr. Anand is left out, Dr. Murugeshan. Good morning, Anand. You are muted. Can you?
Good morning, sir.
Good morning. Good morning. So nice to see you, Anand. How are you?
All
Fine.
well, sir.
Good.
Hi, Anand. कैसे हो? बहुत दिन बाद.
Yes, yes. अभी सर ने सबको जोड़ दिया वापस. मेरा बेटा.
अच्छा.
All well, ma'am. Rishikesh.
हाँ, all well. Rishikesh, all well.
You are unchanged.
हाँ मैम बिल्कुल वैसे ही दिख रहे हैं.
बिल्कुल.
मैम आप कलावती में थे ना?
हाँ.
In
A
the
long time back.
in the year?
In 96 to 2000.
96. तो तब डॉक्टर दत्ता रहे होंगे.
हाँ, डॉक्टर दत्ता थे समय. सुषमा पूल ऑफिसर हुआ करती थी हम लोगों के टाइम.
अच्छा.
आनंद, पूनम तुमसे जूनियर है कि सीनियर है? जूनियर.
2 years junior. She is
अच्छा.
at Rishikesh.
हाँ, पूनम इज विथ मी.
Okay. She was at Ujjain way back.
हाँ.
Great.
न्यूनेटोलॉजी में है मैम आपके साथ?
हाँ, मेरे साथ न्यूरोलॉजी में.
क्या नाम है मैम? पूनम फुल?
पूनम सिंह.
अच्छा, पूनम सिंह. गुड मैम. जर्नल के लिए हम यूज करेंगे मैम. आप ईमेल आईडी वाईडी दे देना मेरे को.
हाँ, बिल्कुल.
Are they from BHU again?
हाँ.
Yes,
इस बार मेजॉरिटी है.
BHU.
बीच वाले.
Mama Ashok sir often talks about you.
अच्छा. You are in Adya?
Ma'am, I am JR2. I'm Adya Shankar, JR2 Pediatrics.
अच्छा. In where?
Ma'am, BHU.
अच्छा, you are in BHU, right? Okay.
So Adya, you have joined through mobile, I guess. If you can turn it like this, so the screen will be full. No, it's not getting back.
वो रोटेशन ऑन करना पड़ेगा तब होगा.
हाँ.
स्क्रीन रोटेशन ऑन करना तब होगा. बट ठीक है. एनीवेज.
Okay, let it be done.
यार वो डॉक्टर मुरुगेशन तो नॉट रीचेबल आ रहे हैं.
And I'm joining this for the first time. Journal ki baat. So we are just going to discuss and comment on various articles that you have shared, right, sir?
I have shared the flow in the group. Please look at
Yes.
it.
Yes.
So
Just
you can just share your reviews and anything pertinent to your practice. I mean, which is beneficial for the practitioner and PGs that you can inform them online. Good morning, Dr. Murugesan. Please join on the please join the meeting so that we can check if everything is fine.
Yeah, just now I logged into my computer.
Yeah, okay.
We'll be starting right at 10.
Dot 10 o'clock. Our editor-in-chief is online. He will start the meeting. And, so Adya is good morning, Dr. Murugesan.
Good morning, sir. Am I audible?
Yeah, you are audible, Dr. Murugesan.
Okay, sir. Good morning.
So Adya won the divisional round of the NNF, and you are in the zonal. You would be appearing in the zonal NNF, Dr. Adya.
Yes, sir.
So Varanasi is in central zone or north east zone?
Central zone, sir.
Central zone. So Dr. Murugesan is also from MAMC and Kalavati, right, Dr. Murugesan?
Yes, sir.
So you did your MD from MAMC
Yes, sir.
and DM from Kalavati, right? I
Correct.
remember. Dr. Amit is left only, so he would be joining soon.
So what do we discuss here, Dr. Abhijit?
You will have 10 minutes. I think I have shown you the flow. In the flow, I
फ्लो
think
मैंने देख लिया, पर उस पे मुझे क्या बोलना है about that
आपको
study?
पूछेंगे कि आपने स्टडी क्यों की, what is the relevance of the study, what are the findings and what are the implications. That's it.
Okay.
Yeah. फिर Dr. Murugesan को, because he is also a neonatologist, he might ask you something if relevant. Dr. Anand will definitely have his view. I mean, some of viewpoints, I'm sure. He's always reading. And, we worked together in CNBC. Anand was my senior resident, so I know him.
Okay.
Yeah.
आनंद हम लोगों की स्टूडेंट था. Anand was a student in DHU.
Yeah, I know.
हाँ.
Dr. Deven, good morning. Dr. Amit को याद दिलाऊं.
Amit must be busy.
हाँ.
हमेशा busy तो रहता है.
Sir is very busy. but he's very well read also.
Ah,
बॉस ज्वाइन कर लो. ओके ओके. Good morning, Dr. Devendra. जर्नल की बात चलছে तो পরে ফোন করবেন.
Good morning, Dr. Siparna.
Good morning, Dr. Devendra.
good morning, sir.
Good morning, Dr. Bhatula. Dr. Murugesan has joined.
Good morning, sir. How are you, sir?
Hi, Murugesan. How are you?
Fine, sir.
And Dr. Adya, good morning.
अमित बहुत रह गया, बस आ रहे होंगे.
उनके ऊपर ही सारा होना से आज तो सब न्यूनेटोलॉजी सिपर्ना मैडम है माले.
आप सब लोगों से रिक्वेस्ट है कि जो सक्सेसिव जर्नल की बात है वो हम भेजते रहते हैं. प्लीज फॉरवर्ड टू डिफरेंट ग्रुप्स. वी वांट टू पॉपुलराइज इट मोर.
Sir, done.
Amit has joined.
हाँ बॉस बताइए। अरे 17 वाली कोर जो 17 वाली है ना, 17 तारीख वाली कोर ग्रुप में है ना, देखिए अभी डाली है, पैनलिस्ट लिंक है उसमें, जो व्हाट्सएप ग्रुप है ना 17। हाँ उसमें ऊपर है ना पैनलिस्ट लिंक, उसमें पैनलिस्ट लिंक है, देखिए श्वेता ने रात को ही भेजा है। मैं आपको दोबारा से व्हाट्सएप पे भेजता हूँ।
Dr. Abhijit, you would be doing the first one then? If he
हाँ
doesn't
मैं
join.
स्टार्ट में करा दूंगा।
हाँ, ठीक।
हेलो, मैंने भेज दिया आपको व्हाट्सएप पे दोबारा से। गुड मॉर्निंग सर, राइट ऑन टाइम। म्यूटेड हो आप, थोड़ा अनम्यूट कर लीजिए डॉक्टर अमित। या
Very good morning, sir.
गुड मॉर्निंग। सो यू आर
I was
राइट।
also, we have a workshop at our hospital only today,
या
and that also begins at 10.
सर
Good morning,
पार्टिसिपेंट्स
friends.
को
I will
जर्नल के
start.
बाद ज्वाइन
Dr.
करा
Abhijit, we will start.
या
Good morning, friends. Welcome to the 24th episode of our monthly program on Journal Ki Baat, wherein we discuss articles published in the current month with the authors and with some of the selected readers. Today, we have an interesting set of articles, mostly from the NICU and the PICU. And I have the authors of two of these articles with me. I welcome Dr. Amit Upadhyay and Dr. Dheeraj Shah, who are my co-hosts for the session. Professor Sriparna Basu from AIMS Rishikesh, and a neonatologist who is the lead author of one of the studies on impact of delivery room gastric lavage on exclusive breastfeeding rates among newborns born through meconium stained liquor. We also have Dr. A. Murugesan from JIPMER, Puducherry. He is the author of the article under discussion, Effect of Electronic Infrared Tap with Voice Reinforcement on Hand Hygiene Compliance of Healthcare Personnel. We also have Dr. Anand Bhatuda, who is a pediatrician with more than 20 years experience and is practicing in Nagpur, Maharashtra. And we have a young colleague, Dr. Adya Shankar, who is a PG student at Institute of Medical Sciences, BHU Varanasi. So welcome all, and I will now hand over to my co-host, Dr. Amit Upadhyay, to discuss the first article. Dr. Amit.
Thank you, sir. Welcome everybody, especially Dr. Sriparna Basu.
Hi, Dr. Amit.
Hello, ma'am. So we have this wonderful paper of impact on delivery room gastric lavage on exclusive breastfeeding rates among neonates born through meconium stained amniotic fluid. It's a RCT conducted at AIMS Rishikesh in Uttarakhand, and it's a very good sized study done on about 100 plus babies, in which delivery room gastric lavage was done, and very pertinent. No respiratory outcomes were studied in this, but feeding outcomes like breastfeeding, exclusive breastfeeding rates were studied. And for this, we would like to have the details of the study directly from Dr. Sriparna Basu, ma'am. So, ma'am, please, all over to you to tell us about this study and advantages of doing this study.
Actually, the genesis of the study was from a systematic review, which was published in 2021 in Indian Pediatrics only. Like where we saw the effect of gastric lavage on in babies delivered through meconium stained amniotic fluid. And the primary outcome variable there was feeding intolerance. and we found the overwhelming difference. It was 0.7 relative risk and risk ratio and 0.5 to 0.8. So almost 4,000. N was almost 4,000. And uniformly, all the authors, they were saying ki there is reduction in feeding intolerance if you do prophylactic gastric lavage. But from our practical experience, none of us, I don't think anybody of us will do gastric lavage unnecessarily in the labor room, that too prophylactically. But in that study, nobody saw the feeding outcomes like exclusive breastfeeding. If you are preventing feeding intolerance, it will have an impact obviously on exclusive breastfeeding. So nobody saw that outcome, and the process of gastric lavage was not was not monitored. Like there was no pulse oximetry, there was no other monitoring. So we conducted this study, and one thing I would like to say about sample size calculation, there was one editorial also in this issue. So there was a comment about the sample size, and we did the sample size calculation keeping the difference of 25% in absolute value, not in relative value. If we take relative value, then the sample size would be more. So in this study, in 110 babies who were inborn, we did gastric lavage in one group and no gastric lavage like convention in the other group. And the primary outcome variable was exclusive breastfeeding rate at 72 hours. So we took 72 hours because we thought the process of gastric lavage will not have its effect at the time of discharge, which could have been the other possibility, because there would be many other variables like between the Baat and the discharge. And the other outcome variables were respiratory distress also we have seen. Duration of respiratory support also we have seen. And mainly it was exclusive breastfeeding rate, ages of first breastfeeding, initiation of breastfeeding within first hour, age of establishment of exclusive breastfeeding, and exclusive breastfeeding rate at discharge. So these were the outcome variables related to feeding, and we did not find any difference. It was 89% versus 87% in lavage and no lavage group respectively. And apart from that, we have seen skin to skin contact, initiation and duration, respiratory distress requiring respiratory support, duration of respiratory support, hyperbile, feeding intolerance, hypoglycemia, polycythemia, total duration of hospital stay, and procedure related complications. So in this, one shortcoming was there because STS we could see in vaginal delivery only. In our hospital practice, it is still not possible to do STS in cesarean section. So we got a reduction in the time to start STS and duration of STS. And other outcomes, there was no difference. Almost all babies during the procedure showed some signs of retching, and many of them developed vomiting after that. So they were definitely uncomfortable for the process. So this was the conclusion, that there is no difference in establishment of exclusive breastfeeding rate, but it delayed the initiation of skin to skin contact and reduced its total duration. And the process of gastric lavage was associated with some amount of neonatal discomfort in almost all the babies. So based on this, our recommendation was like, maybe it is not necessary. You can go away with this if you feel. But definitely sample size was not much. But if you see the power calculation, it was okay, but not for other outcomes. For exclusive breastfeeding rate, it was okay. But other outcomes, I cannot comment. And the incidence of respiratory distress was low, and as well as feeding intolerance was also very low. Like here, we got in the control group around 5%, but in our systematic review, it was very high.
No,
And
no,
I would
like,
yeah.
I was trying to find out like this 55 in each group. So
Yeah.
your primary outcome variable was exclusive breastfeeding.
Yes.
So you must have taken, so this is the your hypothetical number of okay, what will be the exclusive breastfeeding rate in this, and if I do gastric lavage, then what do I expect this to happen? So what was the premise of calculation of sample size?
Okay, we did it from sealed envelope. It was 55%. There was no study which has saw the effect of the exclusive breastfeeding rate at 72 hours. NFHS 4 data says it is 55% in children between 0 to 6 months. So we took that 55% and we expected that there will be an absolute difference of 25%. So one group we took 55 and another group we took 80. So with a alpha level of 0.05 and power of 80%, the sample size was 52. And we added an attrition of 5. You can do it yourself right now. I have done it. It
No,
is there.
that is fine. I just wanted to know those numbers.
Yeah. It was 55 and 80. The same thing will come. You can cross check.
No, that is right. But did you actually anticipate this much percentage increase just by avoiding?
This 25% value has come from the rate of STS reported in the same NFHS. We have written that in discussion. This 25%, they said ki 25% STS is missed. So we took this 25% from that. Like there was no clue how we can calculate the sample size.
And
so this was the basis.
Okay, ma'am. Okay. Exclusive breastfeeding rates were finally quite good. 89 and 87%.
Yeah.
Okay. But age at what will be within first hour breastfeeding rates were quite still low.
Yes, 30%. It was quite low, I admit, because most of the deliveries was cesarean section. Because this is a referral center, so most of the deliveries are 60-70% are cesarean section, and usually there is a delay. Vaginal delivery actually is quite less. So this is a shortcoming, I admit.
Okay. And second is how much volume of saline you use
it was 20 ml.
Gastric lavage?
20 ml single.
20 ml per kilo.
20 ml total.
20 ml total. Okay. So very clear-cut message is there that it is not required. We also at our institute at LLRM, we had conducted this study on use of gastric lavage in meconium stained liquor babies, and we also found same outcome. Though we had a large number of sample size, about 120, 125 in each group, and feeding intolerance was the outcome which
primary
we had
outcome. Yes.
Yeah,
we included your study. Yeah.
Okay. Yeah, it's reference. So I would advise with this background, can we have our experienced pediatricians? Do you use gastric lavage in meconium stained liquor babies or in any other patients? When I came into practice after my training, I realized every baby who is born would get a gastric lavage after birth. Every baby.
Yeah. And probably that is unnecessary, I feel.
Yeah,
yes,
absolutely unnecessary it is. And so sir, in your practice, do you use gastric lavage in all babies?
Yeah, so when we were residents, that time a couple of decades back, each and every baby, whether meconium stained, blood stained or clear, we used to give gastric lavage. And so this is very physiological. If the baby who is in womb for last 9 months in the same amniotic fluid, how is it going to cause amniotic fluid gastritis? So then we evolved over a period of time from routine lavage in each and every baby to those babies who are with meconium or blood. Then the lavage was done. And whatsoever research is being conducted and the discussion goes and the publication comes, I feel there is a delay of at least a decade that comes into the practice. So we need to reinforce the academician, we need to reinforce the same thing again and again through various basically conferences, CMEs or talks. And that's good that we have an online platform, Journal Ki Baat, so that whatsoever research is there, there is a discussion with people who can view and see the things. Our unit, the protocol is to do the lavage for those amniotic fluid which is not clear, be it meconium or the blood stain. And that's the practice majority of the people are following. But going through this article definitely gives a better insight that probably this is not necessary, and hardly we see in the practice, as Shipanna ma'am already said, that the risk of meconium gastritis that we see is hardly seen clinically. That's a prophylactic lavage is done, but clinically we hardly see babies having gastritis secondary to meconium.
Yes, definitely. This is a at times, even if you don't do study, you see you have intuition by seeing number of hundreds of babies, and intuitively we also think in practice now that there is not a lot of feed intolerance or gastritis which is there. So we use feeding gastric lavage now for only babies who have repeated vomiting on
Yes.
feeding,
Yes.
and that's it. So if you have feed intolerance, we would say, okay, give only mother feeding. If he's on top feed, we would say don't stop top feeding, give only mother's feed. And if on giving mother feed also they complained of anything which you give baby is just puking out, then we would say, okay, let's do a stomach wash once, and then we see. So we use the same volume, 20 to 30 ml and of saline, and then we try and feed. And I think that deserves another trial, randomized control trial from this, that okay, feed intolerance babies, does gastric lavage help you or not? With that background,
Yes, once the baby develops feed intolerance, then it is justified. You can try that. But prophylactic doing gastric lavage is probably not necessary.
absolutely, definitely. So with this, do we go on to Dr. Adya Shankar from Varanasi? So the
Yes, sir.
land of. So do you use at your center stomach wash for meconium stain like babies or any other group set of babies?
No, sir, we don't prophylactically do gastric lavage for either blood stain amniotic fluid or meconium stain amniotic fluid, especially if the baby is stable. We have seen that they do develop feed intolerance, but mostly it resolves in 2 to 3 days of life. And the neonates, which, like sir said, amniotic fluid induced gastritis can also be present in neonates. So there are cases when the amniotic fluid is not meconium stained, still babies present with feed intolerance. They all usually resolve by 2 to 3 days of life. And as ma'am said regarding, I just wanted to ask one question actually. Ma'am,
Yes,
as we have seen in many studies, that feed intolerance do develop after meconium stained amniotic fluid. So, ma'am, what could be the reason that if it seems like if feed intolerance is not developing in a baby, early breastfeeding is possible, and feed intolerance is there, then there would be delay in exclusive breastfeeding. So,
Yeah.
is there any additional factor that is affecting that feed intolerance is developing, but the child, we did not get any difference between exclusive breastfeeding between the two sets of patients or units? Means,
See, in how many patients do you see feed intolerance actually? Do you see it very often?
ma'am, not very often. Ma'am, it is, there has been no study, but I think it is comparable between the meconium stained also and this also.
Yes,
But,
I don't think in my personal practice, I have never seen higher number of feed intolerance in babies. And this is very rare. Like Dr. Anand has said that the baby was already swallowing amniotic fluid throughout his or her life. So how come that same amniotic fluid will cause gastritis when the baby is born? And
ma'am,
I
could
don't
it be
think
like incidental finding?
yes, yes,
Could it be
please.
just incidental finding that we are
Maybe
just because
it is that. Unless you record it, you will never know the actual incidence. It is better if you are sensitized, you do record how many babies, all those babies who are developing feeding intolerance, what were the risk factor. It can be very good topic for a small study. You can do it yourself. Once you do it, you will be convinced. Just check the risk factors. Your babies will be babies who are developing feeding intolerance right soon after birth, and you see the risk factor. Like their gestation, their born through meconium stained amniotic fluid, their stomach aspirate was stained with blood, bilious aspirate, whatever. Like you see all these risk factors. Then you will come to know the true incidence. I don't think it is very high.
Yes, ma'am. I think there are various factors that affect, and we are just looking at meconium stained amniotic fluid and making it the culprit of
Yes. Unless you document it, then it is different. Like you cannot be sure. Apparently, often it seems.
I also wanted to ask, ma'am, what was the cause of that delayed skin-to-skin contact in patients of that received gastric lavage? Was it the complications of gastric lavage?
No, not at all. What you do in skin-to-skin contact. The baby is born. You put the baby prone on the mother's abdomen. But when you are doing gastric lavage, you are separating the baby from the mother. You are taking the baby under radiant warmer. You are doing the gastric lavage. The whole process takes 10 to 15 minutes. And then again you are putting the baby. That is the process, the delay for doing the procedure. There is no other pathological thing. Sorry?
10 to 15 minutes.
No, there is not much. That there is not much of clinical implication of 10 to 15 minutes. We have written that in discussion.
Yes.
Like though statistically it was significant, but clinically it may not have any implication. But you don't want to separate the baby from the mother. No? That is the essence of STS. As soon as the baby is born, you keep the baby on the mother. Why to separate?
So routinely we don't do gastric lavage, and we till now in my posting till now I haven't seen any patient with meconium stained amniotic fluid with serious feed intolerance. They usually resolve by 1 days.
You do a small study yourself. When I was in BHU, we also did not do routine gastric lavage unless the baby starts developing feeding intolerance. Otherwise, never.
I think so. There are various outcomes. The primary outcome that we were discussing was the rate of exclusive breastfeeding and skin-to-skin contact. But the more and more discussion is going towards the feeding intolerance, because that's what we were worried about. Clinically, as already discussed, the incidence of feeding intolerance as such is very, very low in exclusively breastfed babies. As Dr. Amit already discussed, that those babies who are formula fed, that's a routine practice to switch from formula feeding to the breastfeeding. And if the breast milk is not available, many of our units are now having human milk bank. So even the donor human milk can help decrease the intolerance. Again, overall incidence of feeding intolerance is pretty low. And whenever we find that, replacing formula feed with the human milk probably helps a lot, rather than the amniotic fluid being stained by blood or meconium. That's what I guess.
Yeah, you are right, Anand, because in here also our practice is to give either EBM or DHM if EBM is somehow is not available. So very few of them develop feeding intolerance after having human milk. Probably that is induced by formula milk feeding intolerance, though which the previous studies used to report.
I think.
Thank you. I think this was really wonderful discussion. Doctor, we are taking the next topic which we are having is nasogastric versus orogastric feeding in stable preterm neonates. A randomized open label control trial done from our capital city, New Delhi itself, by a close friend, Dr. Naveen Prakash Gupta, who is the first author. And this is from the Max Super Specialty Hospital, Patparganj. So it is which tube to put in is a eternal question which all neonatologists have, all staff nurses have, because all preterm will get an NG tube at admission. So whether to put it from the nose or to put it from the mouth is the question. And mouth comes quite intuitively because it's really open, big, easily it goes down. So, but NG tube, there are certain advantages that it is not difficult to, it's very easy to fix and difficult to lodge from nasogastric. So NG tubes tend to last longer because the saliva, which also spoils the tape and the sticking capacity if we are put in the mouth, so it comes out very often. Whereas NG tubes, they tend to last longer. However, newborns are obligatory nose breathers. So if you block one tube by the NG tube and the other one gets blocked by secretion or so, so it can lead to a lot of apneas. So that is the main concern which we have. Does nasogastric tube insertion increase episodes of bradycardia, increase episodes of apnea or desaturation? And thus this study, and it was wonderfully planned study. Good sample size was there. More than 100 patients in each group were there. 100 episodes of insertions were there. About 80 in each group. And this study, it concluded that orogastric tube is preferred to NG tube in hemodynamically stable neonates. And why did this study conclude this? Because it found that mean episodes of bradycardia and desaturations were higher if nasogastric tube was put in as compared to if orogastric tube was put in. So the concerns which we always had were reinforced by this study, and which showed that with use of nasogastric tube, your episodes of apnea and desaturations are more. If you want to know the numbers, the mean difference is about 0.24 with a p-value of 0.002. So significant increase in desaturation and bradycardia is there with use of NG tube. So Dr. Shiparna Basu, ma'am, what is your experience as regard to this? This was a set of very small babies, mostly were less than 30 weeks. About 2/3 were less than 30 weeks, and 1/3 were about between 30 to 32 weeks. So smallish babies were there.
Dr. Amit, we also did a similar study. It was published in Journal of Perinatology, I think in 2020 or 21. I forgot the exact year. So we monitored with pulse oximetry and CRSO2. So we found that during the insertion, there was an alteration in CRSO2, like there was a desaturation, was a cerebral desaturation, and there was, as well as there was hypoxia and apneic episodes. It was more with NG tube during insertion, but we did not do a prolonged study that is underway. A prolonged study like total duration, what is the incidence of apnea and bradycardia. So during insertion, it gives probably more pain to the babies, NG tube insertion.
Okay.
It causes, like in small babies, cerebral oxygenation is reduced. And of course, there are hypoxic episodes and this thing. And we had similar finding with the present study. And in the long run, I do not know what happens. Like once you put, it is difficult.
Okay. And did you also find that use of oxygen increase? Like if there are more desaturations, then people tend to start oxygen, and once you start oxygen, then
it spontaneously resolves by itself. You do not require to give oxygen.
Nobody pre-oxygenates before putting in NG tube that the saturation will come down.
I don't think so. It is transient. It comes up by itself.
It is transient and it comes down significantly. And do you think that NG tubes last longer?
Yes, definitely. Like for our babies who are chronically on feed, we always advise our nurses to put them on NG feed. Otherwise, it is very difficult to give oromotor stimulation. If you keep an OG tube in place, they tend to suckle. And always you will do non-nutritive sucking in small babies. So it is often hampered, non-nutritive sucking and doing oromotor stimulation, which we routinely do in our babies. So in that way, once the baby is out of respiratory support, especially CPAP, Like CPAP, you tend to block both the nose. Like you need an effective FRC. Even in HFNC, we put NG tube. There is no issue.
So, but Vasi, if you think that if the baby continues to suck on the OG tube, then he's actually doing non-nutritive sucking.
Still,
So, which
still,
you
even
actually want to do with other things, but
even giving
doing-
calf feed is also difficult. You will always try, na? Like in a small baby, you will always try to enhance the transition from tube feed to oral feed.
yeah.
And every shift nurse will put another new OG tube. That is another thing. Like baby will chew
As soon
out.
as the baby get active, they remove the tube themselves.
Yes. But they do not take the whole katori spoon feed. Like they will take 5 ml and फिर सो जाएंगे. So you have to put another OG tube and give the rest of the feed. Like this is my experience actually. But putting NG tube is definitely little bit of discomfort for the baby.
Yes. So can we say that general consensus is to, what is the general consensus? Which tube do we use for every, like in a preterm and term babies, if you have to classify, with what will be your instruction to the nurse? NG tube or OG?
For short term, and when the baby is in ventilator or on CPAP, put OG tube. But once the baby is out from ventilator and CPAP and clinically stable, you put NG tube. That is what we follow.
So that is a very clear message for all of us, and which is very good. And Dr. Anand, sir, what do you follow, and what do you see your colleagues do in practice?
Yeah. So this study highlights a very important discussion. Looks very small, but then for the neonatologist managing extreme preemies, definitely every small thing counts. Nasogastric tube versus orogastric tube, we have known through ages the slight advantages or disadvantages that's discussed in the journal as well. But coming to the proper discussion and this topic, the risk of basically desaturations and apneic spills, definitely we need to look into the other factors, that what all interventions were done in either group. Probably the same unit, we expect that this was well controlled in the two groups, but then use of caffeine in the either group. Then how many of these babies required interventions in terms of tactile stimulations or use of any respiratory support to decrease the episodes of apnea and desaturation, whether they were matched or not, that needs to be looked into the picture as well. Then coming to the discussion with Shiparna ma'am, that orogastric tube that interferes with non-nutritive sucking, I agree with Amit sir that in fact that stimulates oromotor stimulation is more with orogastric tube compared with the nasogastric tube. Of course, handling the orogastric tube, because it requires frequent removal and insertion, so financially it may be a burden, but then with the orogastric tube in place, all our preterm babies less than 1200 grams, they will be on orogastric feeding. And believe me that the katori spoon feeding is being done, non-nutritive sucking is being done, all with orogastric tube in situ. So we do not remove this and it hardly interferes. Only thing that the tape gets basically weight, and so we need to keep on changing the stickings many a times, and definitely it needs to be replaced occasionally as well. So it needs to be rechecked after every intervention. But then orogastric tube is presently in vogue in my unit and most of the neonatal units that I do visit. So that's in vogue for the preterm babies less than 32 weeks or less than 1200 grams.
My practice is the same as well. We also use OG tube feeding because I'm really scared of, in private, you are really scared of any desaturation and any apnea or potentially which can happen. And so we also use OG tube only unless baby is ventilated, and then we use NG tube. And so that's it. And how about our friend PG and from BHU? What do you use Dr. Ashok Kumar is there, isn't it?
Yes, sir.
So he is a very senior neonatologist and has been with us for last more than 20 years. What does he advise in his babies?
Sir, we use OG tube only. Never used NG tube till now because surely apnea episodes and bradycardia are seen in NG. Plus pain profile also, I personally I have seen that the baby is more like in pain when we put an NG tube.
That's a
main
wonderful
problem with
thing which you brought out. That's a wonderful thing which you brought out is the pain profile. So that is something very important, and we need to look in that. That pain profile is a good word to use, and which should be monitored in all babies in NICU.
and so that OG tube also act as pacifier or non-nutrient sucking that you are saying, that OG tube. And the only problem with OG tube is that dislocation only, because as soon as the baby is active, they will just pull it out and the nurse or doctor has to put it again. But it is financially it is a problem, but every time the OG is checked before giving feed.
So do you
And
put
cup
in the
feeding is
same
started.
tube? If the baby pulls out, can the same OG tube be put in?
No, sir. Fresh foods. We don't put. Actually, sir, OG tube is in supply, so.
But it can be in supply also.
Sir?
Supply can be short also.
Sir, if it is a dire need, then we will have to do something. We'll have to wash, clean, and do
These
something.
OG tubes are such which can actually be put in again. Okay. And because it is also a cause of patient dissatisfaction. That you tell him that my baby is on tube feed and mother comes to see and say the tube is out. And so that is one thing which we face at time, that mother complains that the sister is not looking after the baby well and the tube is almost every time out. And then you have to explain the mother. It is the thing which can simply explanation will do, that it is good that he is able to take out, because that means that baby is getting active and will be re-put once the baby has to be fed again.
And so they take cup feed. They take cup feed with OG in situ also. Usually there is no problem with that.
Yeah. So
Another point that we need to look into is the type we give feeds, whether that's a pump feeding or the gavage feeding, and that's a continuous feeding versus intermittent feeding when we are using the either group. So that needs also to be looked into and mentioned into this article.
But I didn't get that, sir. What did you say? What's your point out?
How we are giving the feeds. In our unit, we give all the pump feeds. So feeding pumps are used for all the babies who are on feeds more than 5 ml rather than gavage feeding. So,
Okay.
so this also needs to come out in the article, whether that was matched or the unit everyone was receiving gavage feeding, or everyone was receiving the pump feeding. So that's also an important message that needs to be discussed.
Definitely. And Dr. Anand, at BHU, do you before every feed, do you check the position of the OG tube?
Yeah.
Yes,
So,
sir. Sorry.
That is important to do, because OG tubes do get slipped out, and before every feed, one should check the position of OG tube, that it is in place, and or you should have a mark, because it is marked, so that mark where was the tube fixed, and you saw the X-ray that okay, it is up to it is well into the stomach, and then you mark it. Okay, it is usually in a term baby, it is about 18 to 20 centimeters mark. Then you mark it over there, and it should be at that mark all the time. So that is an important precaution. If you take that, then OG tubes are very safe. And so thank you everybody. And so over to Dr. Abhijit and Dr. Deven for the next article, sir.
Thank you so much, Dr. Amit, and finding time out of your busy schedule. You can join your workshop now. Yeah.
Thank you, sir. Thank you.
So with this we come to the third article, which we would discuss, another very important one from the intensive care perspective. So we know that hand hygiene, antibiotic stewardship, and sepsis care bundles are very important measures for decreasing the hospital associated or hospital acquired infections. Now, as promotion of hand hygiene is a cost-effective intervention with higher impact, now newer technologies are tried for improving the same. And in this article on effect of electronic infrared tap with voice reinforcement on hand hygiene compliance of healthcare professionals, we have Dr. Murugesan from JIPMER Pondicherry from the neonatal unit. So welcome, Dr. Murugesan. And what is this, first you need to tell our authors, because it's a new concept, I believe, the electronic infrared tap with voice reinforcement. So first, I would like to you to explain to our audience what it is, then what were the findings of your results and your recommendations. Over to Dr. Murugesan.
Yes, sir. Good morning, and thank you for the introduction. So before going into describing this intervention, I would like to, if possible, show some pictures of how the device look like. Is it possible that I can share my screen?
No, it is not possible.
Okay. Right. So I thought, okay. So I'll just describe the device. So that electronic infrared tap was a device consisting of a. It is basically a device which is connected to the hand washing station or the tap. So there is an LCD display which shows it is timed. So for the first 10 seconds, it will show the first step, and the second 10 seconds, it will show the second step. And there is a small speaker attached to that device, which will say step 1, step 2. And by the time the 60 seconds are complete, it congratulates the user, like congratulations on having completed the full 1 minute of hand washing. So this is what the EIR tap does. So in addition to that, there was a camera installed just above the hand washing station, which is nothing but a CCTV camera, which we usually have in the ICU. So this camera captured the moments, like we know that how many people are using that camera on an, how many people are using that wash station on a daily basis. So this was the camera had a pen drive option, so we can take the recordings from the camera and see how many events were recorded that day. So basically, we are also having a hospital infection control committee, or HICC. So this, in addition to this intervention, there is always a HICC nurse who comes at random times of the day, and they have a software installed in their mobile. It is called IBAR software. So it is made by a third party, but our HICC has procured it, so they are using it. So all ICUs, the nurses go randomly, but they go daily, and check the moments of hand hygiene at the bedside also. So this EIR tap can only sense the moments of hand hygiene when the healthcare personnel enter the NICU or PICU. But in addition, the healthcare nurse of HICC also does it in the bedside. So it is done daily, and still it is being continued. So the idea behind introducing this was we thought baseline to begin with. This was 2 years ago. The hand hygiene complete compliance rate, as defined in the paper, was around 30% only. So hand hygiene total compliance rate, or any hand hygiene compliance, was considered as complete or partial. Like if somebody does not do the full 20 seconds or does not do every moment, so it will be counted as partial. So overall, it was around 60 to 70%. So we thought that introducing this intervention might improve the hand hygiene rates. So that was the main idea behind this intervention.
So before moving further, Dr. Murugesan would like to again need to explain to you. So this there was a LCD screen also with this device, which would show the
steps.
Show the in the form of cartoon. Show the steps of.
It just shows step 1.
Okay.
That is written on it.
Okay. Step 1, and shows that how hand is to be washed in step
Uh,
1, step 2, the six.
Actually, that is not shown. It just says step 1. We are
Okay.
supposed to. It mainly is meant for the duration, right?
Okay.
Sometimes in a hurry, if we do the first step very quicker, so that LCD display was just a prompt to tell that step 1 is still ongoing.
Okay, fine. So in a way, the device is telling you to stick to the duration of the hand washing. Yeah, good. So so what were the results finally? What did you find?
So post intervention, we found that there was an increase in hand hygiene by around 12% in NICU and PICU. So we had calculated the sample size for a 10% increase. So in previous similar studies also, the results have been variable. So in hematology ICU, they have found that it has increased even up to 30%. So in another study in European NICU, they found that there was no difference. So there was a PICU study which showed 10. So we took a number as 10%. So we could actually see an increase in around 12 to 15% in both NICU and PICU. And since the HICC surveillance is still ongoing, like we get this data every month till now. Now we are at around 70%, 75, 76% of complete hand hygiene compliance and around 97% of any hand hygiene compliance. So we can say that even the sustenance phase, we are able to sustain that increase in compliance.
Yeah. So did you also look at the larger question? Was the hospital-acquired infection actually went down, or serious infections also went down during the post-intervention phase in your NPQ?
That was a thing which we tried to see, but we did not see any decrease in the incidence. So we had a lot of reasons to say why it was not the case. One thing was the definitions which are used for this CLABSI and WAP. They are mostly from adult studies. So what was being captured by our HICC was different. Like CLABSI had a definition like the patient should have a fever, there should be low BP in addition to a positive culture. So what they were noting were actually not CLABSI, but our definition of CLABSI was different. So that is something we are still trying to match with the HICC. So one is the way the CLABSI is defined, because the neonatal definitions are not there. And other is we try to look at late onset sepsis as one of the indicators. So it has since we have seasonal trends with respect to our admissions, like September and August is the peak. So the hand hygiene compliance and the in admission rates, they also affect the late onset sepsis rates. So we cannot find a single cause for the sepsis rates, and so we are not able to demonstrate any improvement in the late onset sepsis rates with improvement in hand hygiene complaints.
Okay, thank you, Dr. Murugesan, for the update. Over to Dr. Anand. What are your practice? Before we move on to Dr. Anand, what is the cost of the device? That is also important, you know. What was the cost?
Camera we had, we were using the camera only, which was a CCTV camera, so we did not have to spend for it. The device itself costs around 12,000 rupees.
12,000. So that's not much. So 12,000 is, yeah. So over to Dr. Anand about what is your practice? Do you use similar kind of device in your NICU and PICU? And overall, you must have read the article. So your views on this article, yeah.
Yeah. So I must congratulate Dr. Murugesan to introduce this newer way of reinforcing the compliance with the hand hygiene to prevent hospital-acquired infections. That needs to be thought of, and we know that the single best intervention to prevent any hospital-acquired infection is hand hygiene. Apart from hand washing, I am sure that your unit must also be using bedside chlorhexidine or alcohol-based basically sanitizers. So that also adds on. So our unit, as most of the bigger units, they have HICC, we have infection control nurse, and the single best reinforcement method we found was putting a CCTV camera uh, which records the hand washing, and we have a surveillance. We display the surveillance not person wise, though there is a data, but then it's a group wise basically. So the NICU, PICU, pediatric ward, OT, so the data comes, and average hand hygiene is compliance is around 85%. Of course, it's professionals wise, it's more with the nurses always, then the residents, and then the consultants. So every time it's displayed, reinforced, and very rarely if there is a outbreak of infection, then that particular unit, the meeting is called, reinforcement of hand hygiene, mopping, and all other interventions are being done. Most of now units are working on AHU, the air handling units. So that's also something that prevents hospital-acquired infection. But then must congratulate your novelty of thinking, having an audio visual at hand washing site apart from the camera, which is now well proven that just putting a camera, whether you put the surveillance is on, that just putting this remark helps in improving the compliance with the hand hygiene. But audiovisual, as we all know, that helps in such things. And there are many other things which is time-based, like neonatal resuscitation program. Again, the studies have come that having an audiovisual bedside, timely intervening the things, then that helps improve the compliance with your protocol.
I agree with your point on that nursing complaints being better. We still find it on a monthly basis that nurses often do better than the doctors, and even the staff who are involved in housekeeping and cleaning, they are doing better than the doctors. This is what we have found. So I think that gives us another opportunity every time to tell our doctors. The other reason could be probably because residents are posted on rotation, so every time orientation has to be done anew. So that is one observation we also agree, like nurses always fare better in these hand hygiene complaints intervention.
So, Dr. Adya, that brings me to you. So, in this article, there is a specific line written which caught my attention, and I would dwell upon to you. The residents in this study was the poorest group as far as the hand hygiene compliance is concerned. So over to you. What do you think are the factors, and basically your perspective, how the hand hygiene percentage might be increased among residents in NICUs and PICUs, because they are the group of, apart from sisters, they are one of the very important groups who would be taking care of the babies both in NICU and PICU setup. So that is probably the message that we need to strengthen this group of partner in managing babies. So your perspective on it? Yeah.
Sir, I totally agree that hand hygiene is the most basic thing, and it is often missed by residents. In defense of residents, I can say that sometimes the situation there is some emergency situation. I have also, without sanitizing, I have intubated the patient, which is not like the protocol. But sometimes you have emergency situations and you have more bigger things than sanitation to maintain. But apart from that, it is also true that most of the time that hand hygiene is missed. So that, though, I think it is we just have to spread awareness for that and more compliance. This device is a wonderful device. We are not using it. We can use it. And I would like to suggest that if we can add steps also, like visual steps, what the steps of hand washing. And we should extend it to the attendance of patients also. Because in NICU and PICU, we allow attendants to come and see the patients. Yes. We tell them to wash hands, wear the scrubs, but they are not literal enough that to how long to wash hands, how to wash hands. Being doctors, the minimum that we can do is not add to the infection and add to the disease that the child already has. So residents know awareness only, because we already know what is the pros and cons of hand hygiene. We just have to reinforce it, and this camera is a good reinforcement, because we are always afraid of being found out that we are doing something wrong. So camera is a very good intervention for residents, but I would also like to extend it to the attendants and all the people who are coming in contact with the patient, be it the attendants, the staff, the other, every person.
So that is another important perspective you brought out, and very rightly, that nowadays, I mean, I think most of the NICUs and PICUs, one attendant is definitely there with the patient to take care. So that's another important area of research, whether introducing these kind of devices and intervention to the attendants would also decrease, infection rates in the NICUs and PICUs. So, Dr. Murugesan, another aspect was which I forgot to mention was the UTI rates were less among. There was a correlation with the hand washing along with the UTI rates in your PICU or PICU, I think, in this study.
PICU, NICU baseline. We looked at only the catheter-associated UTIs. So NICUs usually diaper weight is done, so we did not have any difference. But in PICU, the reason for this reduction in UTIs, we were not sure whether it was due to this improvement in hand hygiene complaints or it was a chance event, because the observations were also not continuous. There was a significant gap, so it was difficult to say whether the intervention was responsible for that improvement.
Okay, finally.
I think so that mindset is important. The mindset of nurses are different compared to residents and consultants. Consultants thinks that they are going to spare less time, so they are going to have less touching the kids or the trolleys. So the compliance, and they spend less time in an ICU. So the compliance of hand washing is slightly less compared to residents. So residents have a mindset that they are in a hurry, they are emergency, they need to have a frequent hand washing. So all this needs to be reinforced continuously, that this is a simple, single, most cost-effective method of preventing hospital-acquired infection. And the surveillance, especially putting a camera or putting a novel devices, those units who can have, but the simple thing that keep on reinforcing amongst themselves, keep on educating yourself that hand washing is important.
Exactly. Especially the finding that the hand washing, the hand hygiene rates are of nurses are superior to the doctors. Puts us into a responsibility position more so the consultant. So if you want to bring about a change in our areas, then we have to lead from the front.
Yes.
So the onus is on the consultant. So if they follow the proper hygiene, it is more likely that the residents will also follow the footsteps. So with that, I think we would close the discussion on this article. But in the clipping section, I would like to mention two articles. One is there is a update on the American Academy of Pediatrics 2023 guidelines on evaluation and treatment of children and adolescents with obesity. So crisply written article onto the various aspects of identification, evaluation and management of childhood obesity. So you should read that article. There's another systematic review on iron formulations. Very commonly we deal with iron deficiency anemia, and we prescribe iron. So what iron formulations are available, and which iron preparation, what are the various side effects. So so you can also go and read these two articles. Apart from that, there are other articles as well in this issue of Indian Pediatrics. I think with that, we are coming towards the end. Only 2 minutes are left. So over to Dr. Devendra Mishra for his our editor-in-chief for his final comments and closing of this issue and announcement of the next date.
Thanks, Dr. Vijit. So we had an interesting discussion. Important one thing which I wanted to stress was about the update which was there on the AAP guidelines on obesity, as this was important because very soon, probably next month or the month after that, we would be having our own IAP guidelines on management of obesity in children and adolescents. So this gives an important baseline information for that, and those interested may look at the whole AAP document. Again, another good one which I think Dr. Vijay Sir, despite his interest in nephrology, missed was the short course therapy for pediatric UTI in the Journal Club. So that is a good article, and the viewpoints of the various experts is good, and the original article definitely. And despite the strong statistical positivity, none of the experts seems to agree to the results, and that's always good to see that hard data sometimes doesn't really go well with the experts who are working in the field. So our next episode will be the last Sunday of October, and I thank all the audience members and the panelists for an interesting discussion and for informing us more about the background related to these studies and how these studies affect the practice for residents and the practitioners. Thank you all. Thank you very much.
Thank you very much.
Thank you.